Welcome, everyone. Thank you so much for joining me for this talk on healthcare inequities impacting people with disabilities. I am Dr. Stephanie Van. I'm assistant professor at the School of Medicine in the Department of Physical Medicine and Rehabilitation, and I'm an interventional pain specialist. My pronouns are she, her, and I'm a Vietnamese female with long black hair wearing a navy blazer and a couple of buttons representing Johns Hopkins Disability Pride Month because I'm recording this in July, and I'm sitting in front of a blank white background. I just want to preface this talk by saying that this talk is not just all me. I collaborated on the content of this talk with many people, one of whom is Carrie Devlin. She's a professor and she's also a senior music therapist in the Department of Neurology. She gives a great talk on unsettling ableism in medicine. I also collaborate with the Disability Medicine Curriculum Advisory Board, which is made up of faculty, staff, and students who help inform changes to the curriculum like this talk. I collaborate with the Equal Access in Science and Medicine and the Hastings Center, which is a biomedical think tank that focuses on research dealing with people with disabilities and the health inequities they face. So this is a team effort. So the learning objectives today I'd hope to focus on is that by the end of this talk, you recognize opportunities to confront ableism throughout healthcare. You'll be able to describe major health inequities affecting the disabled patient population. You'll describe how these inequities manifest and intersect with other social determinants of health. And hopefully, you'll be able to replace biased language with more inclusive and equitable terminology. Here's a meme that I grabbed from Instagram. A doctor is saying, "You're disabled, but you're so smart." And then me colon dot 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 dot. So before we really jump into this talk, I want you to think of someone in your life who has a disability. This could be a family member, a friend, or an acquaintance that you've met during your training. Picture them in your mind. What do they look like? What have they been through? I challenge you to do this throughout this talk because it's important that we put a face to some of these statistics and some of these generalizations, because at the end of the day, we're healthcare providers who are going to be helping people throughout our careers, all kinds of people. The person that I'm going to be holding in my mind throughout this talk is my soon to be 90-year-old grandmother, who is very sweet, lovely, and very deaf. So here's another meme from Instagram. Going to the doctor when you have a chronic illness. What people think it's like, a very straightforward pie chart of 4 different quadrants. You go to the appointment, you get diagnosed, you receive treatment and support, and then you heal your body and get better, right? Pretty straightforward. But what it's actually like is a pie chart that's made of multiple colors, different slices that overlap. You're waiting months for an appointment, you're going to multiple appointments, you're left untreated. Some treatment strategies are ineffective, or you're dealing with a lot of side effects, and you're experiencing worsening or new symptoms. All on top of this, you're dealing with some medical gaslighting. Unfortunately, that is much more close to a reality of what a lot of our patients face. So here's some harsh realities that make this talk so important. There is a severe lack of understanding amongst healthcare professionals when it comes to caring for people with disabilities. So I want to quote the work of Dr. Lisa Iazzoni. She's a disabled scholar at Harvard. She coined the term diagnostic overshadowing, which is the phenomenon in which clinicians interpret all symptoms reported by a person with a disability through the lens of the disability, even though those symptoms might actually not be related. They might be a new problem that's undiagnosed, but this results in suboptimal care. So she published a recent survey of 714 physicians, and 35.8% of those physicians reported knowing little or nothing about their legal responsibilities under the ADA, or the Americans with Disabilities Act. 71.2% answered incorrectly about who determines reasonable accommodations, and 20.5% did not correctly identify who pays for these accommodations. Even with all of this lack of knowledge or misunderstanding, a majority, 68.4%, felt they were at risk for a lawsuit under the ADA, meaning that even though physicians don't have a good understanding of this, they still fear legal consequences. Yet, for some reason, that's not a good enough motivator to improve their understanding. One of the more shocking statistics here is that only 18% of the physicians she surveyed strongly agreed that the healthcare system treats disabled patients unfairly. I want to say that again. Only 18% of physicians acknowledged that the healthcare system treats disabled patients unfairly. 18%. That is just such a small minority. So, when we're talking about disability, what does it look like? Well, one example you already have in your mind is the person in your life who you know with a disability. The National Council on Disability sums it up well. Disability is a natural part of the human condition, which occurs across all age, gender, racial, ethnic, language, and social groups. The ADA, or the Americans with Disabilities Act, was passed in 1990, and it defined disability as a physical or mental impairment that substantially limits one or more major life activities. With the caveat that if a disability is not obvious to an employer, then they can ask for medical documentation from a healthcare provider like you and I to confirm the need for accommodation. So, as providers, we have a responsibility to understand this stuff and help people live their lives. Fast forward to more recent years, the Affordable Care Act, or ACA, was passed in 2010 under the Obama administration. And this is the first time there was standardized collection of health data, which included disability status. So, more specifically, a yes to any of these following items was considered a disability under the ACA. So, deafness or serious difficulty in hearing, blindness or serious difficulty in seeing, serious difficulty in concentrating, remembering, or making decisions because of a physical, mental, or emotional condition, 5 years and up. Serious difficulty walking or climbing stairs, 5 years and up. Difficulty dressing or bathing, 5 years and up. And difficulty doing errands alone, like visiting a doctor's office or going shopping because of a physical, mental, or emotional condition, 15 years and up. So here is a nice cartoon depiction of what disability can look like. What you're seeing here is portions of a cover of a book called Demystifying Disability by Emily Ladau. You see cartoon depictions of people of all skin colors, all sizes, all ages, hair colors, clothing choices, different mobility devices like prosthetic limbs, canes, wheelchairs, walkers, and different people around them like children or family members, and even service animals. Disability is diversity. The disabled community is the most diverse minority group, and anyone can join it at any time. About 1 in 4 US adults have a disability, and 1 billion people, or 15% of the world's population, experience some form of disability throughout their lives. Disabilities can be apparent or invisible, congenital or acquired, and disabilities can impact a person's identity, medical care, personal assistance needs, mental health, family and social interactions, and lifestyle. Basically, anyone can experience a disability, and to ignore this part of the population or to act like this is not a serious issue that healthcare providers need to attend to is uninformed. So let's check our ableism. We know about racism, we know about sexism. What is ableism? Ableism is oppression, prejudice, stereotyping, or discrimination against disabled people on the basis of actual or presumed disability. It's also the belief that people are superior or inferior, or have a better quality of life, or have lives that are more valuable or worth living on the basis of actual or perceived disability. This specific definition I took from Lydia X.C. Brown, a disabled scholar out of Georgetown. And I just felt it was a good, concise definition, but there are many others out there, and these are open to interpretation. At the end of the day, we all experience some ableism, inherent ableism, systemic ableism, cultural ableism. It's inherent throughout our medical system, our healthcare system, and our society. Now that we're more aware of it, we can more proactively confront it. So I just want to give you a quick overview of the history of discrimination, marginalization, and exclusion that people with disabilities have experienced since the birth of modern medicine. Pictured here is a facility called the Rosewood Center. It was actually opened in 1888 in Maryland, and originally it was called the Asylum and Training Center for the Feeble-Minded. After a long history of abuse, mistreatment, and oppression, the center finally closed in 2009. I could dedicate a whole other lecture on the history of disability, discrimination, and oppression. Suffice it to say, it's a dark past. There's institutionalization, there was forced sterilization and eugenics, slurs like idiot, dumb, imbecile, retarded, lame, psycho, gimp, cripple, spaz, all stemmed out of this movement and are inappropriate and offensive and unhelpful. There's medical gaslighting, gatekeeping, and trauma that happens. People, even to this day, will address only caregivers or family members instead of a disabled person in a healthcare setting and in general. There's infantilization, or treating a disabled adult as if they're younger and not as mature as they are. There's objectification, and that can be positive or negative, like considering someone to be only their wheelchair or only their assistive device, or considering someone to be super inspirational and, putting their likeness on a poster to motivate someone who isn't disabled to do better or not complain as much. That's all objectification. There's also pathologizing, which happens so much in modern medicine, where someone isn't referred to as the person that they are, but rather the disease or the condition that they have. All of these issues stem from dehumanization. And when people with disabilities or people of any marginalized group are dehumanized, their humanity is taken away from them. And that is where inequities and discrepancies and healthcare disparities can stem from. All right, so I'm going to do a quick knowledge check. Do you remember what percentage of physicians agree that the healthcare system treats people with disabilities unfairly? Do a lot of physicians agree, or not enough? You correctly remember that only 18% of physicians agree that the healthcare system treats people with disabilities unfairly, which means that the other 82% of physicians lack this key understanding. But after this lecture, you're not going to contribute to this. Good job. So here's another meme from Instagram. It's an old-timey skeleton wearing a coat and a top hat, ringing an old-timey doorbell. And the meme says, "The doctor heading into my appointment without reading my chart, ready to gaslight the bleep out of me." So here's a summary slide that addresses all the broad inequities that affect disabled people. And when we talk about disparities or inequities, we're talking about health differences that are avoidable, unnecessary, unfair, and unjust, and not primarily caused by the underlying disability. So people with disabilities face higher costs of healthcare, higher rates of preventable illness, decreased access to appropriate evaluation and diagnostics due to bias and lack of accessible facilities and equipment, and in general, a decreased understanding by healthcare professionals and research due to lack of education and lack of data. So keep these four major themes in mind: cost, preventable illness, lack of access, and lack of understanding by the people who are supposed to be helping them. All right, so here's a slide addressing the cost of living with a disability. So disabled adults are more likely to delay or forgo medical care because of cost. They spend more than 4 times as much on medical care compared to non-disabled people, while being less likely to have private insurance. The financial consequences of disability, like loss of income and medical expenses, causes declines in other social determinants of health, like housing, transportations, and social relationships. Disabled people are 50% more likely to have a catastrophic health expenditure than non-disabled people, according to the World Health Organization. And then disparities are especially stark for uninsured disabled Americans. So up to 36% of uninsured disabled Americans can't access necessary care, compared with only 9.5% of uninsured non-disabled people. And often these people can't even afford necessary medications. Here's some more general inequities of living with a disability. People with disabilities have a lower life expectancy. They are 3 times more likely to have arthritis, diabetes, or a heart attack. They're 5 times more likely to experience a stroke, COPD, and depression. They're more likely to be obese and have unmet medical, dental, and prescription needs. Disabled women are more likely to receive poor maternity care, and they're less likely to be offered a pap smear or a mammogram. People who are deaf or hard of hearing are 3 times more likely to report only fair or poor health compared to those without hearing disabilities. And unfortunately, recently, research has come out describing people with intellectual developmental disabilities experience higher fatality rates due to COVID-19 when they're living in group homes. I want to take a moment to talk about intersectionality, which is a term coined by Kimberly Crenshaw in 1989. Intersectionality describes the complex cumulative way in which the effects of multiple forms of discrimination, like racism, sexism, and ableism, or classism, combine, overlap, and intersect, especially in the experiences of marginalized individuals or groups, to produce and sustain complex inequities. So when it comes to thinking about how health inequities persist, categories like gender, race, class, and disability are best understood as overlapping and mutually constitutive rather than isolated and distinct. That being said, people with disabilities often represent multiple marginalized identities. So disabled women are more likely to receive poor maternity care, less likely to receive a pap smear or a mammogram, and disabled women with breast cancer are less likely to have breast conserving surgery or radiotherapy, and this is likely due to perceived desexualization of disabled women. Disabled people in rural areas and or people of color who are disabled, they face even more barriers to accessing healthcare. And coming up is a nice infographic by the CDC that shows that people who are Black and Indigenous Americans are more likely to be disabled than people in other racial and ethnic groups. So here's that infographic. 3 in 10 people who are American Indian or Alaskan Native have a disability. 1 in 4 people who are Black have a disability, whereas all the other races quoted in the statistic, white, Native Hawaiian, Pacific Islander, Hispanic, and Asian, those statistics are slightly better. All right, time for another knowledge check. Out of all the statistics we've talked about, and we've talked about a ton, just pick one. Write down one statistic. Could be really simple and broad that describes a health inequity that affects the disabled population, whether that's a specific type of disability or people with disabilities in general. Just write it down. Remember it. Keep it in your pocket for later. All right, I want to quote the National Council on Disability again because they summarize these inequities so nicely, and they've already done the work for me. People with disabilities have more medical needs, but they use the healthcare system for disease management instead of disease prevention. Medical equipment for care and diagnostics is largely inaccessible, so people with access needs don't always get a full evaluation on an exam table, an accurate weight on a scale, offered thorough diagnostics, etc. Healthcare data is severely lacking when it comes to the disabled population across the lifespan. So medical research is very limited in its understanding of this particularly underserved group. And finally, current clinical providers are severely lacking in their knowledge, familiarity, and ability to serve the disabled population. They recommend that it should be standardized across all US healthcare professional schools to require disability competency education, like this lecture. So well done, you're way ahead of the game, to be quite honest. All right, here's another meme by Spoonies_United from Instagram. It shouldn't be so hard to explain to your doctor that the years you've lived with an illness mean you know things about it they can't learn from a textbook. I think this meme really emphasizes the point that the best way to keep learning about people with disabilities is hearing from people with disabilities. They are the experts on their experience, and they know how you can help them best. All right, a little side note about lifelong learning, because that's the field that we have chosen. I'm going to be talking about language in the next few slides, and language around disability is an evolving issue, just the way language around gender, sexuality, and race, culture, all of that is evolving. We're having very important discussions right now, but we're still figuring things out, and it's okay to make mistakes, and it's okay to not be 100% right all the time. The important thing is that you're always learning and that you're always open to feedback. Basically, this time next year, this language that I'm going to be describing to you might be outdated or inappropriate. As healthcare providers, the communication and documentation that we do every day during our work days is one of the major ways we can consciously counter bias and best help our patients and ourselves. If you're unsure, just ask. Just ask your patients what language they prefer. That's one of the best ways to not perpetuate bias. All right, so here's a slide that I came up with of just a bunch of unhelpful terminology that I actually hear very, very often in healthcare settings. I'll just read some of this stuff off, and hopefully you can think of some better terminology that's more helpful, accurate, and less biased. So obese, fat, and heavy, emotional, dramatic, crazy, addict, drug seeking, drug abuser, poor insight, poor health literacy, rambling, long-winded, homeless, mentally ill, special needs, differently abled, mental retardation, wheelchair bound. All of these terms, unfortunately, I've seen in multiple healthcare settings, multiple institutions, lectures, textbooks, you name it. It's pervasive throughout medicine, this unhelpful bias terminology. So let's try to change this. Let's try to use terminology that does not perpetuate bias. I have more descriptive, helpful terminology that is not so biased. And again, all of this is in flux. So better words might come along that will replace even these words. I like baseline instead of normal because what is normal anyway? And everyone's baseline is different. Disabled instead of special needs, or whatever someone's preferred identifiers are. Also, specific access needs instead of special needs is much more helpful to a healthcare provider and their patient. Wheelchair user is definitely the preferred term instead of wheelchair bound. Other helpful terms are high BMI, decreased endurance, coping support, history of trauma or PTSD, needing frequent redirection, mental illness or mental disorder, needing cognitive support or simplified summaries, facing housing or financial insecurity, and substance use disorder. All of these things are medically accurate and still very helpful, but do not perpetuate bias as much as the other terminology that we've described. I want to refer you to some more comprehensive guides on inclusive language in healthcare because this is a very in-depth topic. So, one is published by the American Psychological Association and it's called Equity, Diversity, and Inclusion, Inclusive Language Guidelines. And then the other one is a Guide to Language, Narrative, and Concepts, which is published by the AMA. So, I highly recommend you check these out if you're really interested in this healthcare terminology. All right, another knowledge check, real quick. What is a preferable term that replaces wheelchair bound? That's right, wheelchair user. Very good. Another check-in. Remember the person in your life who has a disability? Picture them in your mind. I've got my grandma on my mind all the time. Do you know about their preferred identifiers? Do they identify as having a disability? Do they even care about an identifier? And what would they change about their past experiences with healthcare? Something important that you could easily ask them. All right. So what's the bottom line of this talk? We work for and amongst people with disabilities. They're our bosses. We can help reduce healthcare trauma with an inclusive approach to clinical care, and this helps everybody, our patients, their families, us, our colleagues, everybody. It's never wrong to ask someone about their preferred identifiers or access needs. And we don't always have all the answers. So instead of saying things like, I can't help you, or there's nothing I can do for you, it's much better to say, I don't know. Let's figure this out together. Here's a meme of Boromir saying, one does not simply create memes about accessibility, even though I've included several in this talk. As we wind down on this talk, I wanted to refer you to a couple of other resources, actually more than a couple. So the top video here is by the Department of Homeland, no. The top resource here is by the Department of Health and Human Services. It features interviews with people with disabilities talking about their healthcare experiences and how the healthcare system could do better. The second video is published by the Special Olympics and focuses on kids and people with intellectual disabilities. Both are great, quick, awesome watches. Even more resources I want to refer you to, especially coming from a healthcare standpoint. Here at Hopkins, actually, we have our own disability equity podcast called Included, hosted by our very own Dr. Bonnie Sweenor. There's also a podcast called Docs with Disabilities that's hosted by Dr. Lisa Meeks and Dr. Peta Poyos, sponsored by the University of Michigan and Stanford. That's a great listen. And there's a national group called the Medical Students with Disability and Chronic Illness, which started at Stanford, but now they have chapters all over the country. They're doing awesome work and helping to really lift up and represent disabled voices within the healthcare community and the healthcare trainee community. And finally, in the middle, I've featured Demystifying Disability, the book that I referenced by Emily Ladau. It's a great, accessible, quick read or listen as a resource to anyone who's interested in learning about the disability community, who wants to be more of an advocate or more of an ally, but doesn't know quite where to start. Start with that book. And finally, I'll just include a shameless plug because I talk about this stuff all the time. I'm a very passionate disability advocate and ally. So I have a YouTube channel called This Ability Clinic, and I feature interviews with people with disabilities. I feature breakdowns of TV shows and movies that feature or depict disabilities. And I just have lots more tips and tricks for people in and around the healthcare system for how we can do better. So feel free to check me out, like and subscribe. Here are some references for you in case you want to read more in the medical and healthcare literature about all the inequities I described. Here's even more references. Please feel free to just reach out to me if you have any questions or want to get more involved in the Disability Medicine Advisory Board or want to make a video with me. I'm very open to your ideas. Thank you so much for listening attentively to this lecture. I really appreciate it. And I'm excited for you to move forward throughout your training with the goal of being an inclusive, compassionate, and knowledgeable healthcare provider that serves all types of people. Thank you.